Hello, everyone. And you are watching Get Well with Mel, and I am your host, Melissa D. Hall, and we have health and wellness information for the mature adult. And you all, we have a show for you today. As you all can see, I have a guest. Well, the doctor herself, Dr. C. Nicole Swiner here. And listen, we are covering everything today. All your burning healthcare questions, all of the things that you all are seeing online regarding health. We're going to cover those vaccine questions that you all have, like should you be taking a vaccine? Is gel nail polish really causing cancer? What else? How to prevent kidney failure? We have some high blood pressure questions. And listen, if you listen, we got it all. And she's written a lot of books, okay? So so make sure you go ahead and share this episode out. As always, tell a friend to tell a friend to tell a friend to tune in to Get Well with Mel. And as you come in, say hello, okay? Hello. Share this episode out. And what I'm going to do right now, I'm just going to go ahead, share this out on my Facebook, okay? Because how can I tell you all to do something that I'm not doing, right? Does that make sense? It doesn't make
Practice
sense.
what you preach.
I have to definitely practice what I preach, okay? So let me go ahead and do that right quick. Alrighty, let's go do this. Oh. So tell me, as you all are coming in, where are you all coming from? Where are you all calling from? Well, watching from.
Oh, that was an old school radio.
I know, right? Where are you all calling from? Listen. Speaking into existence, I'm trying to have people call in. That's the whole goal, right?
Yeah.
It is, because it's all about them. It's never really about us. It is. So I love to connect with everyone. So let's see here. Sending this out to y'all. Okay, at your friends, at your family. Okay, do all the things. Oh my goodness. Alrighty. All right. So, Dr. Nicole Swiner is a board certified family physician, owner of Swiner Hydration.
Serenity Hydration.
Serenity Hydration.
I love it.
Yes, and Swiner Publishing, and a 3-time author. Is that right?
7-ish times.
7-ish. Okay, listen here. 7-ish.
Doesn't matter how many times.
What they say now, like this, right? That's what this is, like this. All right. Yes. Speaker and also a medical advisor for Black Girl Vitamins. Is that right? And media personality. So you all, we got the right person. I know she just came out with a new book titled Healthy Kidney.
The Healthy Kidney Handbook.
Yes, the Healthy Kidney Handbook, which is obviously, it says it all. And most notably, her other book, what is it? Superwoman.
How to avoid the superwoman complex.
Yes, how to avoid the superwoman complex. So welcome, Doc.
Thank you for having me.
You're so welcome. You're so welcome. So listen, so much is going on right now in the healthcare sphere, right? How do you feel being a doctor on how political healthcare has become?
That's a really good question. So I'm having flashbacks of the pandemic when, COVID first hit.
Yes.
Being in the clinical space, trying to protect people's lives, trying to educate them on everything that was happening, trying to keep myself safe, my family safe. It's a shame that politics has to get involved with how we take care of ourselves.
Absolutely.
And that is from the top down, whether it's from the government making certain rules and stipulations to the insurance companies having to say on whether or not you can afford things or whether or not you can have things done that your doctor thinks that you should have, down to the pharmacies, can we afford them? I mean, like from the top down, it's ridiculous. So it makes our job hard, and often we take we're the fall guys, right? We take the blame for decisions that are out of our hands. And so it makes it complicated with your relationships with the world. It's almost as if healthcare professionals it's an us against them situation.
Yes, it is.
And then it's hard to really have that great relationship with your patient often, or your client if you're doing consults and all that, because you get the blame for the medicine not getting covered, for them not being able to do the CT that they want. You get the blame where it's actually not your fault. So it's hard. And what I try to do and what I try to talk to people about on media, on social media, is it should not be adversarial. Like, we are not the enemy, right? Even when it comes to we make recommendations on things that we think are healthy. We'll talk about vaccines in a moment, but when COVID, came out and the vaccine was available, it came out quickly, and that gave a lot of people pause. And then as the physician trying to explain why we should get these things, and then people reading things in the media or seeing things that, politicians are getting involved with, which have nothing to do with medicine, but, we have to fight that. So it's just complicated.
And the insurance companies as well.
It's a mess. It's a mess. It's a game you have to learn how to play. If you're going to be a physician nowadays, unfortunately, you have to play the game. You have to learn how to be, unfortunately, how to work around politics, work around the insurance companies or whatever rules or regulations they have in the way. We have to go outside of that and figure out, how can I still take the best care of my patient?
Interesting.
Yeah.
So when it comes to that, right, navigating the politics of it all, navigating the insurance companies, we hear so many stories recently about how doctors have had to stop surgeries in order to deal with billing. That's right. Have you ever been in a situation like that?
Not necessarily from a procedure or a surgical standpoint, but definitely when it came to, if I thought a patient had a mass or something that was really concerning, and I wanted them to get, let's say, a colonoscopy sooner than it was recommended for them to get.
Yes.
Or if they had a family history of colon cancer or breast cancer, and they wanted to get those screening tests done earlier than the recommended age, which changes all the time, the insurance company doesn't necessarily agree with that. So do they pay out of pocket? Do they just have to wait, for some unfortunate event to happen? So that's where I would come across those things in primary care. And then when it comes to medication, for instance, the GLP-1s, right, which has a lot of politics and controversy mixed up in that. If I think this drug is going to save someone's life, if I think that this drug is going to prevent someone from getting diabetes because their mother, father, grandmother, aunt, everybody has diabetes in their family, I think as a medical decision, it's a good decision. Their insurance company isn't always going to cover the medicine if they don't meet certain requirements. So those are the ways that I would have to kind of struggle and find ways and think outside of the box, and we'd have to work our way around it to get things done.
Absolutely. That's it's just so disheartening.
Yeah.
And, I'm in the insurance industry, you all. I'm in the Medicare industry, for those of you all who do not know. Okay. And this whole weight loss drug thing has been a thing.
Yeah.
Right. And recently, Medicare has decided they weren't going to cover it. Right. And then they put a disclosure that they would cover it if you had a heart issue.
Right. Certain things have to be met.
Exactly. And I'm like, but if they lose weight, right, they wouldn't have a heart issue. And,
there you go.
Right. Exactly.
Right.
Exactly. It's crazy. And believe it or not, and I've been on a weight loss journey. I've lost like 40 pounds over the past 2 years.
Yeah.
Yes. It's a journey. And I never knew how much your weight affects things. Like, your weight not just gives you high blood pressure, because I was watching her video on her YouTube. She has a YouTube channel, right? You can shout out your YouTube channel if you want. Okay.
Doc Swiner and everything.
Just that. And on your YouTube channel, you were talking about high blood pressure and how, of course, stress management, but how losing weight could help with your high blood pressure.
Absolutely.
And when I was heavier, I had high blood pressure, right? And so being overweight affects high blood pressure. It affects, what else? Sugar. It affects cancer.
Yep.
Your risk for cancer, of course.
Your joints,
knee replacements, heart disease, everything. So, giving them these medications, I know, and it's super expensive, right? And that's a thing too that they're looking at. But still, preventing is worth an ounce of cure.
That's right.
Yes.
You get it.
I get it. But
the folks that control the money bags don't get it.
it's unfortunate.
Yeah.
And I definitely feel, I know you said that you felt or you feel like you're to blame, right? Or the customer,
we often get the blame.
Yeah.
The patient call, we're the ones that get the angry phone calls,
Yes.
when the things get rejected or blocked or denied or declined. The doctor's office is the first one to get the angry phone call, usually.
But don't you think that's changing now?
I hope so. So I'm no longer within the clinical space for multiple reasons. Some of that was because of that.
Really?
I was burnt out, right? And then the pandemic was like the straw that broke the camel's back. But I've been outside of the traditional clinical walled-in space for about 3 years now, and kind of doing my own thing. So with Serenity Hydration and Wellness, I do more stress management consultations, weight management. How to I want to work my way off of my blood pressure medicines with the help of my physician. How do I do that? That kind of a thing, and hydration and vitamins on the side. But that has allowed me to work outside of the insurance situation. Yes, it's out of pocket, but people can also use like their flexible spending accounts and their HSAs for wellness. And so I've been able to help people in that way, and then hopefully not have to deal with a lot of the bureaucracy that comes with running a clinical practice. And God bless my folks, particularly in primary care, that are still running clinics and taking care of people. But my hope is that you're right, that it is getting better, that patients are now able to kind of educate themselves on what else is happening. They are actually calling the insurance companies and complaining, calling the pharmacies and complaining, the pharmaceutical companies, and getting involved, whereas hopefully the doctor, the nurse, the admin team, they aren't the only ones carrying that burden of, we got to get this medicine covered, we got to get the situation taken care of. So hopefully now everybody is involved as a team versus the blame game.
The blame game. And I definitely feel, especially with the rise of technology nowadays, that it definitely has more like empowered patients.
Yes, hopefully.
Yes, I think so. I think so. Even dealing in a senior market, a lot of times my customers, they'll go ahead and call the insurance company first. Yeah. So let's kind of switch gears here. When it comes to the relationship with doctors and patients. One of the things that I have found is that a lot of people don't trust doctors anymore. They don't. They think that you all get paid for giving them drugs. Do you all get paid for writing prescriptions?
Not.
Okay.
No.
Okay, guys, one more time. Just
1,000 times no.
Please soundbite. Do doctors get paid by pharmaceutical companies for writing prescriptions?
Absolutely not.
Okay.
Not.
You all heard it here first. Because a lot of people believe that.
Yeah. I hear you. I hear you. Now, I will, so back in the day, if you go back to I would not call it the good old days, but if you talk to some of the older peers and colleagues, back in the 70s and 80s, like there was a more symbiotic, supportive relationship between a doctor's office and a pharmaceutical company, because they're pharmaceutical reps that work for these companies.
Yes.
They go out and they go to clinical offices and spaces and tell you what, new research and new medications that are out. And yes, they would have a dinner program, or they would have a workshop, or they will bring a lunch to sit down and talk to the providers and tell them about things. Were they cutting checks for you to write prescriptions for the medications? Absolutely not. But I think that's probably where people got that idea.
Okay.
Was that, y'all get to go, to these lunches and dinners with these reps. So clearly, y'all are getting the benefits of writing these particular prescriptions. But no, doctors write for the medicines that you need, and that will hopefully help you recover from whatever ailment you are suffering from. Okay. And we don't get paid for that.
Okay, well,
we barely get paid by the insurance company.
Barely get paid.
Barely get paid.
So let's talk about that.
Visits,
so
right?
let's talk about that, right?
Yeah.
Because people are under the illusion that doctors make a ton of money. That you all are multimillionaires. You are swimming in the cash.
Where? Where's mine? Where's my $1 million check?
Okay. So could you tell the people?
Absolutely not. I mean, unless you are a super duper subspecialist, right? Okay. So you work on this part of the heart of children with this particular type of cancer, and you have studied for decades to get your degree, you deserve to make multi-million dollars in the OR. You're saving lives, right? Primary care folks like me, family physicians, pediatricians, internists, the ones that are on the ground, we're the soldiers that are taking care of people on an everyday basis, trying to prevent these things.
Yes.
I'm just trying to pay back my student loans, right?
Really?
So essentially my mortgage is almost equal to the student loan payment that I'm still paying back, and I'll be paying that back forever. So no, we do not make multi-million dollars.
Really?
No, most particularly family physicians, if you go look in the parking lot of a family doctor's office, there's a bunch of Subarus and Nissans and we are doing what we got to do to take care of ourselves, take care of the patients, take care of our families. Hope to have a couple of vacations where we can have a little time off and take our families away for, just some rest and relaxation. But no.
Oh, wow.
No.
Well, thank you for clearing that up, because I think
Yeah.
some of that really lends to the mistrust
Yeah.
between people in the medical field, because
Mhm.
a lot of times they're like, oh, they're just going to get paid for me taking this prescription. They just want me to come to their office because they get paid. It's all about you all getting paid.
Yeah. Now we need to get paid for our work, right?
Yes,
So there is some, we need to be rewarded for the work that we are doing, but we get paid just like you go to a dentist office. You see the patient, you do the procedure, you take care of them. Their insurance sends in the amount that, you should be getting more, but the insurance pays you what they think your time and energy are worth. And you don't get anything above that unless you are a cash only. There are some offices now that don't accept insurance.
That's correct.
Direct
concierge medicine.
Concierge boutique medicine.
What do you think about concierge medicine?
I'm all for it. If it works well for the patient and the doctor. I have some friends that left the traditional clinical space, left the hospital system, and started their own like DPC, direct pay care, I think is called, where you essentially pay a yearly subscription.
Yes.
Right? And you pay your yearly fee, and out of that year, you're going to get this physical, these amounts of labs, these amounts of procedures, etc. And then your doctor essentially is on call for when you need them. If that works for you, then so be it. I think as long as the patients are getting the right care and the doctor feels well enough compensated for the amount of years that we were in school and the time and the energy and the thought process it takes to take care of a patient, I think is fine.
Okay.
Yeah.
All right. Well, I love that.
Mhm.
A lot of doctors that I know, they are moving towards that.
Mhm.
I
That's
don't-
kind of what Serenity Hydration is my wellness practice.
Okay.
It's essentially concierge.
For those of you all who do not know, again, what concierge medicine is,
Mhm.
concierge medicine is a situation where you can self-pay the doctor
Mhm.
without insurance.
Yeah.
Like you said earlier, you could quote unquote buy your membership,
Mhm.
and it comes with special privileges
Mhm.
such as 24-hour access, direct home care,
Mhm.
things of that sort. And I know a lot of doctors, they have done this to not have to deal with the insurance
Mhm.
company.
And it makes it easier for the patient.
Yes,
Yeah.
to provide better care.
Mhm.
I guess though, in some ways, I see it as the haves and have-nots, kind of broadening that.
Mhm.
When it comes to health equity, what do you think about that? In that
So
case?
it depends. So the folks that I know that have their own DPC practices, it's essentially the amount of money that you would pay for your insurance. So through your job, they take a certain amount of money out of your check every month to afford your insurance plan. That money is essentially what you would be paying the physician so that you can have access to your care, or your mid-level providers and nurse practitioners and PAs are starting these practices too. So you have to look and see, how much money am I paying for an insurance plan that I may or may not be using all of the benefits of, because maybe you don't wear glasses, or you don't need to come in 3 times a year. You only really need to come in once a year for your physical, that kind of thing, versus keeping that money and then paying out of pocket or doing a once a year membership. So not all of them are an exorbitant amount of money to afford. So there are places that you might even spend less money going with a DPC practice versus paying out of your check for an insurance plan that you may not actually use.
Can you talk about some of the costs that you've heard for concierge medicine?
So let's see. So I have one friend, or one social media colleague on Facebook that has a really successful mobile OBGYN concierge
Really?
practice. Yes.
That's
And you pay, I think 1,000 or more, I don't want to misquote, a payment situation per year, but essentially you have access to him when you need him. So if you need a doctor visit in the middle of the night because you have some emergency that came up and you don't want to go to the emergency room or the urgent care, which costs lots of money outside of your insurance plan.
Okay.
He'll come right to you and do the testing and do the treatment and write the prescription and do everything that you need at home. So for a lot of people, it's worth it. You just have to kind of weigh your pros and cons, look at how much money you're spending, compare it to what you would be spending, and see if it makes sense for you.
Okay, great.
Yeah.
Well, before we move on to the hot topics, I just want to ask you one thing.
Mm-hmm.
You mentioned about not getting paid from the insurance companies.
Mm-hmm.
How often is a doctor not getting paid by the insurance company?
Fairly regularly.
Would you say over 40% of the time a doctor isn't getting paid by
So
the
I
insurance
can
company?
only speak from my experience.
Yes.
When I was working in clinical practice, we worked first for a hospital system that owned our practice. And so they were in charge of doing the billing and getting the money and then cutting the checks for everybody, for their salary. And then we moved to a more private practice model where we had a management company that would help us with the billing, but a lot of the billing we would still do in-house, meaning inside the clinic. So we were more involved with seeing what the charges were, how much the insurance is going to pay, how much the patient was responsible for, and then we'd have to turn in those claims and then wait for the money to come, right?
How long could that take?
Sometimes months.
Really?
Sometimes months. Sometimes there were some Medicare plans where they would only cut a check like once a year.
No.
Right? And so, or we'd have to wait 3 months to get our check.
And you got staff to pay. People don't get this. It's a business.
Girl, burnout. That's what I'm saying. Burnout.
So that's part of the reason why you left.
That's part of the reason. Yeah. There were months, so as an owner, it was me and my co-owner. We owned the practice, but we had a staff of 15 or more people who also had to be paid. And there were some months that we, especially during the height of the pandemic, where sometimes we weren't even in the clinic in person because it was unsafe. We had to do virtual visits. Number one, the insurance companies were not covering virtual visits the same that they would an in-person visit, but it was the pandemic. We couldn't go in all the time, or the patient didn't feel safe coming in because of the pandemic. People were either canceling or getting sick, couldn't show up to their appointments, etc. There were some months where the owners would not get paid.
Wow.
Because when the money comes, you got to keep the lights on. You got to pay the rent, for the place that you're in. You got to pay everybody's health benefits and their checks. And sometimes that money that we took home was zero. And we still did the same amount of work, right? And so it's hard. It's hard to maintain.
I can see that. So just in general, out of all your claims, how many with the insurance, the percentage, would you all as the doctors not get paid for?
I think eventually we would get paid for all of them because it's illegal. They have to pay you for the services that you provide. I would say the ones that were maybe very delayed, 20-ish%, we'd have to wait sometimes for.
At least how long?
At least a month to 3 months.
Really?
Oh yeah.
But can't they, but you said they had to pay you, but sometimes can't they deny a claim though?
Oh, absolutely. Oh yeah. Not only that, but they can, let's say a patient came in for their physical exam, right? So most insurance companies, Medicare is often different, but most insurance companies will say, okay, your yearly physical is free, meaning you come in the door, you get your labs done, you get your pap smear, you get this, you that, your annual physical, you are not required to pay anything out of pocket. They're saying this to the patient. But then the patient comes in and, had to take off work or had to make special circumstances to come to the doctor's office and they can't come back, regularly. So they're going to go ahead and, by the way, while we're doing this, I've had some depression come up, or I think I might have a UTI, or while I'm here, can we also talk about this weight loss drug? That's extra outside of your physical. Legally, we have to say, yes, we also talked about these things and we did some labs and I wrote a prescription outside of the physical exam. I have to code for that. We have to code for that. Not all insurance companies will pay for that though, right? Because they said, you said you were just going for your physical and so it's free, but then you also want to do this other stuff. So either the patient's gonna have to pay for it or we're not paying the doctor even though they did extra work.
Wow.
Right? And so it just becomes like this fight. It's like, but I want to take care of I know the patient can't come back next week. Let me go ahead and try to take care of this stuff while I'm here. and I can't pretend we didn't talk about your UTI and I gave you a prescription for an antibiotic. I have to document that. But if I bill for it, I might not get paid for it. So girl,
that's where it comes in. That's
so
where
I was like, I'm out.
Yes. I don't blame you. And then your malpractice insurance is crazy. So I get it. I get it. I get it. All right then. So let's get
the medicine is fun. Practicing medicine is fun. The business is medicine, not always fun.
Yes, absolutely. Yeah. I mean, that's really the feedback that I hear from a lot of doctors.
Yeah.
So let's get into some of the hot topics here today. Right now we are going through a big fight about vaccines. Vaccines, if we should have vaccines, anti-vaxxers, all the things. In Florida recently, they got rid of their vaccine requirements for the children to go to school. Okay. What are your thoughts on that?
You see my face?
Yes. What are your thoughts on that? Do we need vaccines?
Gotta be very careful. I don't want to get in trouble politically or whatever.
I get it.
But so from my perspective, to answer your question, the short of it is yes, we need vaccines. We need vaccines. We benefit from vaccines. Vaccines have saved lives. Even if you are against getting regular vaccines on a regular basis, there's no way you can argue with pandemics that we were able to clear up with the invention and the lives that we've saved with the invention of vaccines. When's the last time you heard of a kid having chickenpox?
It's been a while.
When's the last time you heard of somebody having polio?
It's coming back.
It's coming back. Do you know why it's coming back? Do you know why it's coming back? So my husband and I have this discussion all the time. He's like, yeah, remember we were little, people would have chickenpox parties. If you were
I had the chickenpox.
If one kid on the street had it, they would, like the moms would get all of the kids together because they wanted everybody to go ahead and get it over with. We can go back to school.
That's so dangerous.
When's the last time if you had
I've never been to that. I've never been to a chickenpox party.
Oh, good. You don't hear about that anymore because we are not getting chickenpox anymore because of varicella, because we have the shots, right? Same with polio, but as you mentioned, coming back. Same with measles, but I'm sure we're going to talk about that too. But we get MMR shots before we go to school. We get chickenpox shots. We get polio vaccines. There are so many benefits to not only, of course, preventing you from getting sick, but preventing you from giving it to somebody else who's sicker and saving their life, right? Herd immunity. So you can't, unless you have a significant history of, you've not been able to tolerate the shots, or you had this horrible, effect that happened the last time you got a shot, and so that you're fearful of I get that. But outside of that, or if you're a cancer patient and you're on chemo and your immune system is very low, you want to wait maybe, or you maybe want to skip this year if you're getting the flu shot. Okay, we can talk about that. We can have those conversations. But being, across the board against all vaccines and against all the research that shows how it helps prevent us from getting sick and from dying, particularly like COVID, it's hard to argue that.
Okay.
Yeah.
So.
And I don't judge.
Yes.
Right? Because that's the oath we take as well. We don't judge.
Is that right?
Yes. Don't judge. We have a conversation, but it's hard to reconcile. You want to protect this person, save their lives, help their children, and it's a hard argument to argue against.
Okay, so let me ask you, say we have somebody watching out here who they're just I don't want any vaccines at all, I don't want to take them. But if you had to name, I guess maybe the top two, if you're going to get any vaccine at all, whether you're a kid going to school or you're an adult, which vaccines do you think a person should just get, just period? And all that rest, we can come to later.
Right now, flu and COVID. Me and my family tomorrow, we're all getting the flu and COVID shots at the same time. Like, give it to us, boom, boom. Let's get it done. Because flu season, which usually doesn't start until end of September, October, seemed to start earlier this year. There are a lot of people that got flu August, which is unheard of in many years. So kids are back in school. Let's go ahead and get this flu shot because we don't have time to be sick, out of school, out of work, taking care of people, right? Number two, COVID. And COVID has its political stuff going on too, where there are some areas that won't be able to get the COVID shot without a prescription.
Oh, wow.
There are some people that won't be able to get the COVID shot at all because of access. There, the teams that get together, the CDC groups that get together and talk about, the trends and the strains and all of that, they've not been able to meet. Some people have resigned and left these businesses and these organizations because of the political things that are happening. So that's why I'm like, if you can go ahead and get it, go ahead and get it. Because we don't know how long we'll have access to these things.
Absolutely. Well, let me ask you about this, right? Especially like the flu vaccine. In order to get the flu vaccine, from what my understanding is that it's made from the flu. They give you the flu to stop the flu.
Kind of, sort of. So it's not the live virus. So they are not giving you the sickness, the illness, the live virus. They are giving you the killed particles from the virus as essentially an email to your body to say, hey, this is what this thing looks like. If you come against it, go ahead and build up some antibodies now. So when you see the real thing, you know how to fight it. So that's how it works. Same with COVID.
Okay. Well, my thing with this flu vaccine, because to be honest, personally, I have never had a flu shot, ever. Because everyone who I know who has had a flu shot has gotten the flu, like they've gotten sick before. They took the shot, then they got super sick. They got the flu basically.
Okay. And so it has side effects from the shot.
Yeah, every person I know who's gotten that shot has gotten sick.
Yeah, it's the opposite for me. So, and myself included. So almost everybody, I've been in medicine for almost 20 years. Almost everybody that I know that's gotten the flu vaccine, including myself and my family, almost no one has side effects or any problems taking it. And if they do, they have minimal effects. They may get a little bit of a temp, they may get a little bit of some achiness, a little bit of a headache. Tomorrow, when we get the flu and the COVID vaccine, I definitely expect us to feel a little bit tired, a little lethargic. When I first got the COVID vaccine, it definitely, and I know we're talking about flu specifically with your question, but definitely felt kind of the effects of my immune system kicking in. Does that mean that I had the virus and I was sick from the virus? No, that just meant my immune system was responding to the vaccine, and it was building up antibodies to it.
Okay.
Yeah.
So with the COVID vaccine, let's talk about that. Again, that's one that personally I've never got the COVID vaccine because I was just really nervous about it. It was new. I did not want to be experimented on. Okay.
But now 5 years later, how do you feel about it?
No.
The same.
I'm so sorry. Not unless I really have to, because I have seen a lot of side effects from people from it. They've come out with a lot of reports saying that there have been side effects from the vaccine.
There are definitely side effects with all the
people
vaccines.
died from taking the COVID vaccine.
I've not heard that.
Okay.
Yes, I've not. That has not been my experience.
Okay, that's good though.
Yeah.
That's why you're here to talk about it.
So my experience has been, yes, you will get side effects. There are potential side effects with all the vaccines. So that's from, polio to chickenpox to the measles, any of them, right? Because as your body elicits an immune response and you're building up antibodies, it's the same way that if you actually have the infection, you will build up antibodies. But the risk with having the infection is hopefully you'll make it out of the infection okay, right? With the shot, I've not had, and again, this is my experience. I'm sorry, I keep hitting the mic. My experience, again, almost 20 years in medicine, last 5 years talking about COVID stuff, I've had 0 people to pass away from the shot itself. Can I say the same is true for those who were unvaccinated and got COVID? Unfortunately, I cannot. I've seen many deaths. And if there's this much chance that I can save a life, with encouraging you to at least have the conversation about what makes you fearful about it, or where you might be getting your research from. I might have a completely different perspective. I'm going to tell you what has happened with people that I've seen and treated. Then let's have that conversation. But ultimately, the decision is yours to make.
Absolutely. Well, just for the people and from my understanding, how are they able to come out with the COVID vaccine so fast?
So the key is, and I forget the sister's name, it's actually a Black woman from North Carolina.
Yes, and went to Chapel Hill.
That's right. That's why I forget my sister's name. But she was actually on the team that helped to essentially put this vaccine out. The truth is, we've had this technology. It's been a while since I've talked about the COVID vaccine, but we've had this technology for decades. The technology, meaning the way that the messenger RNA, mRNA is how it works, the way that that is delivered to the body and then the body elicits an immune response to, we've had this technology for decades. So the COVID vaccine in its purest form is not new. It's been around for decades. The brilliant researchers were just able to say, you know what, we could deliver this protection in this technology that we've been using these years. Let's see how that works. That part they were able to come up with fairly quickly because they're smarter than me. They're smarter than most of us in this research. But the actual mRNA technology we've had that for decades.
Okay.
So essentially, it's not new.
Okay.
Yeah.
Well, thank you so much.
You're welcome.
I for explaining that, because I think because it came out so fast.
I get it.
People were like, "Hold on,
I get it. I get
I'm
it.
not taking anything."
Especially Black folks who are like, "Wait a minute, like who who discovered it? Who's giving it?" I get it because there's a lot of distrust. There is.
It is a lot of distrust.
Yeah, but thankfully, I was able to kind of be there on the front lines, particularly as a primary care physician. At the time, I was doing a lot of, we talked about doing media and news and stuff. I was able to, go on WRAL and talk about this stuff through my own personal experience, because I tested positive for COVID fairly early in the game, probably from clinic, who knows, or it may have been a false positive, I don't know. But I was able to get the shot probably like that, so if things hit the fan in March, I got the shot probably sometime in like December as it was first coming out. And I talked very openly about, what am I thinking? What am I fearful about? Why do I want to get this shot? Why do I need to get this shot? And so we had a lot of conversations about that as it was happening. And, thankfully, my husband, has risk factors. I have young kids at home. I don't want any of them. If I can help prevent them from getting sick and having complications from COVID, which we now know can be lifelong lasting, I'll do my part. And so thankfully, knock on wood, the shot every year since then has worked well for us.
Okay.
Yeah.
Well, very good. Very good. So one of the things I want to talk about, let's see here. And this has been a hot health topic. Okay. So in Atlanta, right, there was a story about them getting like 40,000 HIV cases this year, right? Is that true?
I don't know. I can't say because I'd have to see and read the study that you're referring to, but I don't want to speak and
misquote.
It's not true. It's not true.
It's not true.
Good.
I did the research.
Good.
Like less than 20,000 HIV cases in Atlanta.
Okay.
So it's not true.
Okay. So that's better than 40,000, but still a lot. Yeah. With all the things that we know, right? All the prevention techniques, whether it's as simple as a condom or as complicated as taking PrEP, with all the things that we know, it's always alarming to me how many folks not just get infected with HIV, but with STDs in general. It's almost like we don't know about it, but we've been talking about it, like we know, right? How it's transmitted and how to protect ourselves and how to get tested regularly. But for some reason, we continue to struggle with those types of infections. The world.
Okay, well, let me ask you this. As far as a hot topic take, gel nail polish, right? So a study
took mine off recently.
You did. So a study came out about it causing cancer, and I think over in the UK they have banned gel nail polish.
Yeah.
What are your thoughts? Do you think does it?
So I'm concerned. I'm a committed gel nail girly.
Oh, yes.
Every 4 to 6 weeks getting my gel. And so I'm worried. I'm concerned, and even as even before we knew about this, sitting under the UV light and getting that UV exposure, I was concerned. I would even sometimes put sunscreen on before I went because it's a direct light to your skin and your cells, right? And yes, Black and brown folks don't get skin cancer more than white folks, but there is potential for skin cancer. So I was concerned. Number one, knowing that, we as a nation, we are always behind the times when it comes to figuring out these things in research. So the fact that the UK has already figured this out and we haven't said anything yet makes me worried.
Okay.
With all the political things that are happening with research, money and government funding of research is getting snatched. So we may not even have enough money to look into it now, right?
Wow.
Personally, for me, This is what I'm going to do. So again, I'm that committed gel nail girly every 4 to 6 weeks. I'm going to take a pause. I'm going to take a little break from the gel.
Really?
I'm going to take a pause. I'm going to see what's going to happen. Because, yeah, there's this TSO chemical that they identified as the thing that is the problem with gel. So instead, maybe I'm going to do powder. I'm going to try powder next.
Okay.
Or just do the regular old-fashioned way. And you do dip.
No,
you
like
like
the powder, it's the dip powder. That's expensive though.
But you know.
I know, well, it saves your life, right?
You know?
It saves your life.
Or just keep it old-fashioned at home and do my own nails. But yeah, I think I might back up a little bit from that. I was impressed enough by what the research showed, even though it's in a different country. Right across the pond, right? And so why should there be anything different between the gel they're using over there and the gel that we have over here? It was enough for me to say, okay, I might take pause. I might wait a little bit.
Can you expound a little bit on the chemical that is harmful?
So again, the research is early, but apparently this TSO, when tested in animals, turned, and mutated cells into malignant cells in different types of cancer. So that's what happened. And then I can imagine having the UV light that then potentially stimulates that chemical is probably not a good thing either. So, yeah.
Okay.
Doc Swiner is gonna hold off. Well, then my manicurist is like, wait a minute. We'll try some other stuff, but yeah, I think I'm gonna fall back just to see, because again, our government is taking away money from research that needs to be done. So who knows when we'll be able to do our own research and figure this out.
Yeah, so let's talk about that, right? Since the government is taking away research to fund medical science, where do you suggest that people go in order to get medical advice? Like, what is a true source now?
Your physician, period, point blank. So if you don't already have a trusted primary care or physician or nurse practitioner or PA that you've seen and you trust, get you one, right? Because we're going to be the ones that care the most. This is what we do and what we took the Hippocratic Oath to do, to take care of people and give them the right information. So, we're going to care the most. We're probably going to get the information that is available the soonest, right? So we usually will get the research and the data and the statistics before it comes out in the media. We are holding on to the tried and true stuff. We're holding on to, because a lot of this stuff on like the CDC, a lot of the guidelines are being erased. They're being removed from websites. So I'm in a couple of different Facebook groups, a couple of different doctor groups where we are literally copying and pasting and making our own documents, like keeping them for us. So that, because if they take them away and remove them, you can't go online and look up, right?
Thank you.
So if you don't already have one, if you don't already have a trusted medical professional that is going to be your go-to, find you one. Because, we're struggling trying to keep things, in line and even keeled. Yeah.
Well, let's talk about that, because you're saying just go to your doctor. Now we have this whole fight about getting health insurance, and doctors, again, you said it, you all want to get paid. For example, in DC, they have taken away the Medicaid from a lot of the people there. 25,000 people are going to be uninsured in DC, not even at the end of the year, like right now it's happening. What do you think is going to happen to those people?
Those people are going to get sick. I mean, I hate to say that. It's going to be really unfortunate for people that don't have access and don't have resources, or don't have the wherewithal to drive to another city, or do concierge or do DPC. There are going to be some unfortunate numbers that happen because of it. We just pray that those people can stay the healthiest that they can, and then I don't know. We'll have to see.
One of the plans that I've heard they were trying to do for those people is to send them to the minute clinic. You have emphysema and they treated you at the minute clinic.
Yeah. Okay. That's going to be a lot. Okay. Hopefully our health departments will still have, they're government, a lot of those are state funded too. Jeez. I don't know, y'all. It's going to be interesting. But I'll be around. Y'all can text me or DM me or social media. You can trust me. That's right. But no, I'm being for real. Like, even if it's on social media, you have those healthcare professionals, those doctors that you trust, that have been vetted. that you've known them for years, and they tell the truth and they're good, shoot them a DM, ask them a question, yeah, it's going to be interesting.
Okay, so get into that too. Seeking medical advice, right? What we are facing now is a lot of healthcare racism.
For years.
For years. Yeah. For years.
Yeah.
What does that look like? So how can a person tell if they're being discriminated against?
Yeah.
From a doctor.
So sometimes you don't know, right? So there's overt discrimination and racism, and then there's silent. You may not know that you're not being considered for a certain medication or certain treatment because of your race. You may not know that that's available. My key has always been just find someone that you're most comfortable with, that you have rapport with, that is vetted. Maybe your friends or family have seen this person and they trust this person as well. I have a lot of people that say, well, I want to find someone that looks like me, right? Is that always the best decision? It may not. Okay. And again, people have told me, I went to, so-and-so, and I thought it was going to be a good fit because we have a lot of similarities, but it didn't end up being. So that may not always be the case. Find someone that you have rapport with, that you can ask those stupid questions to, that is well vetted, and like I said, if a lot of family members, a lot of friends that also have seen this person and they trust them, go ahead and connect with that person, create a healthcare relationship with that person. My prayer also is that just as a medical field, a discipline, that we are getting better, right? We're decreasing the bias. We are decreasing a lot of the stigma attached to Black folks not feeling pain,
yes, that's a big thing. They say, we don't feel pain. Do they teach you all that in medical school, that Black people don't feel pain?
No, but I'm Black. I mean, I don't know. I don't know. It's because I'm Black. I didn't get those lessons.
You didn't go to a Black medical school.
I didn't. Right. I didn't. And no, I was never told outrightly, right? But go back to the 1950s and 1960s, there are some books. Thankfully, they weren't taught in the lessons that I learned, but there are some books that essentially say that, melanated skin is thicker skin, right?
Wow.
So melanated skin doesn't feel the same things, or pain tolerance, because Black folks are so strong and resilient. I think it's a bias now, not necessarily things written on paper, but it's a bias to think, okay, well, Black women are strong and resilient. She can take that. What is a level 10 for someone else may not be level 10 for her, because she's strong. She can fight it. She can do it. That we're getting rid of that. We're actively having those conversations. But if people come in with their own biases, that's a harder issue to, they grew up thinking these things versus learning it in school. That's a harder situation to fight. So
absolutely. So
I pray it's getting better. We're having more conversations like this. Yeah.
I love that. So before this interview, I was watching something online, a story about a woman, very well educated African-American woman. She had a baby. She had her second C-section, and she ended up hemorrhaging, bleeding to death. Her husband said he told them, hey, my wife's not doing well. And they told him, oh, she'll be okay. When the autopsy was done, she had 3 liters of blood. If we feel, any person feels in a medical situation that they are not being heard, are there some buzzwords that we can say that will start to raise an alarm in a physician's head to make them pay attention a little bit more?
That's a good question. So, we've heard the same stories with Serena, same story with Beyonce. Buzzword. So if you're dealing with, let's say you're dealing with, that's a good one. If you're dealing with maybe a resident physician, or you're dealing with a fellow, okay? And not all situations are like this, by disclaimer. Many of my peers and colleagues are phenomenal physicians, will take wonderful care of you. Again, I don't want to create an adversarial relationship,
I
right?
Understand,
but if you have, say, a resident physician or a fellow that is not the attending physician, right? Or a nurse that you feel may not be treating you well, asking for their attending is kind of the next step. It's like asking for the manager, right, or the supervisor. So who's the attending physician, right, is number one. Or if, like I said, the nurse doesn't, it's just not gelling, you don't feel like that, you can ask for another nurse to be on duty, right? You have that right. Or you can ask for her manager to come in. So that would be my first, is asking for the manager, right,
So,
or you're attending.
Yes, so if you have a nurse practitioner, you say, well, can I speak to the attending physician?
Correct.
I love that. So, all right, what if you're in the hospital? Okay, I had a situation where I had to be with someone in the hospital, and the nurse was supposed to come to them every 3 hours, and that was not happening. What should you do?
So having an advocate, like you said, you had to go and be with someone in the hospital, having an advocate with you, your emergency contact, if they're able to come into the hospital and be kind of your person to hear what's going on and take notes and to kind of feel the vibe and see if you're getting the attention that you need, is definitely helpful. In the hospital, there are social workers that are on staff. You can always ask to page a social worker. You can ask to page the chaplain, right? The religious person, right, in the hospital.
They're probably like, this person thinks they're about to die.
Yeah, no, I just need your help. I need you to, we're going to pray, but then I need you to also go find somebody that can help us.
They can be an advocate for you.
They can. So, yeah, so if I were, let's say I were in that situation with a loved one, I would definitely look for the attending. If the attending isn't really, giving me what I need, I would maybe even look at the chief, who is the chief of that department. And then I would start looking for people that are the chief may not be on call that night and may not be there.
Yes.
There's a social worker that's there. There's a chaplain that's there. Like, I'm gonna get somebody's ear to say, this is not happening and this needs to happen now.
Okay.
Yeah.
Well, thank you. I love that. I think that is so necessary. So you recently wrote a book called The Healthy Kidney.
The Healthy Kidney Handbook.
The Healthy Kidney Handbook. Look, I just get it all wrong. Okay.
One word.
You just released it now. Actually this summer.
Yeah.
When you did that, when you wrote it, who did you have most in mind?
Us. Okay. Yeah. So initially, this is the first book that I was asked to write by a publishing company. Most the other books that I've written, I self-published through my publishing company. So this was the first company. I need to go back through the email trail. I don't know if they found me on LinkedIn. I'm not sure where Ulysses Press, which is part of Simon & Schuster, I don't know where they found me, but sent me an email. They were like, we know that this is kind of outside of the stuff that you normally write about, but we're writing organ-specific books. We want to write one about the kidney, and you're in family medicine, you've authored before. Would you be interested in writing about the kidney? And I was like, yeah, I guess, I don't usually write about the kidney, but of course, when you think about it, hypertension, everything we talked about, hypertension, diabetes, dialysis, renal failure, transplant, cancers, all this stuff related to the kidney. So if I can talk about what happens ultimately, hopefully it'll help people prevent those things before you get that, or talk to their families about their family history. If we're talking about genetic kidney illnesses or renal illnesses, talk to their family about what's gone on in their family. And hopefully that would reduce some of the incidences of things that we can prevent. So the more I got into it and wrote about it, of course, the more the statistics come up, and you think about who is affected by a lot of this stuff, and it's us, it's Black and brown people. Okay. So it became even more important to write that book.
I love that. So could you just tell people out there, what are the statistics for like kidney disease?
Yeah, I mean, you think, unfortunately, almost every illness that you can think of, hypertension, diabetes, etc., we are at the forefront. Not only are we diagnosed more, but we're diagnosed in later stages. So once renal disease or renal failure is caught, usually it's at the end stage. We're in stage 3 or 4, right? Where there could have been a lot of things happening in stage 1 and 2, or we might have been able to prevent it altogether if we'd gotten our blood pressure under control, or if we gotten our diabetes under control, or if we quit smoking sooner, that kind of a thing. And so almost all of them, and there's a particular genetic disease called PKD, or polycystic kidney disease, that a lot of us have. So in general, by the way, kidney disease in general, 1 in 7, in the world will suffer from some form of kidney disease that may lead to failure. For us, it's more like 1 out of 3.
I can believe that.
It's always going to be that for most illnesses. But But yeah, that's why it's even more important for us to be aware.
And when you're saying us, can you just say who you're talking about?
Black folks.
Okay, all right. Just say just
Black people.
Black people, because you can
The
say women.
diaspora.
It could be women. It could be women.
Yeah.
All right. So what are some of the things that lead to kidney disease? Because to be honest with you, you say 1 in 7 for in the world, 1 in 3 for African Americans. Like I told you in our pre-meeting, I have never met a white person on dialysis before.
Interesting.
I've never, and I've lived in many states, and I have never met one.
Interesting. So what you said? What are the things that lead to it?
Yes. What are some of the things that lead to kidney?
So the biggest two that we've said repeatedly: hypertension and diabetes. The big two, right?
How does that happen? Because high blood pressure is so common, so is diabetes, but high blood pressure is kind of just treated like the flu nowadays, right?
It's rampant, right?
It is rampant. So how does that lead to a kidney breakdown?
And it's complicated because it's often silent. Like we don't always know that our blood pressure is high or how long it's been high, because you won't always have that physical like headache and blurry vision and all that. That's not until it gets really bad. But what happens is your kidney, so you have most people born with 2 kidneys, and there are blood vessels that connect to the rest of the body and help to regulate sodium, potassium, calcium, vitamin D, all that good stuff. Those blood vessels that connect from the kidney to the rest of the body are muscular, and so they constrict, and get really tight sometimes, and they dilate and open when things want to flow. Blood pressure literally causes constriction. If your blood vessels are constricted, then your heart has to push harder to flow blood out of it, and that's where the pressure comes from. Your heart having to push hard. And if your blood vessels are tightened, then your kidneys aren't getting the blood flow that they need, or they're not getting the filtration, or they're not able to dilate well enough to get toxins out of your body through urine. And so once that happens, inside the kidney starts to break down. The little nephules and tubules and all that stuff. They're not getting the circulation of blood flow you need, and your body's not getting the poison out that it needs to get out. And so that's how kidney failure works with that. With diabetes, it's a nerve disease. Diabetes affects your nerves. So the nerves of the kidneys, the blood vessels too, but the nerves are what take a hit. So your sugar comes in, causes inflammation, eats away at the nerves and the vessels. The kidneys can't function the way that they need to. That's kidney failure.
One of the things you also spoke about too is smoking as well. Is that because it constricts?
Yep.
Okay.
Definitely. And then the toxin itself is toxic to the inside of the kidney.
Okay. What about smoking weed? Is that still considered smoking?
No, not nicotine. It's nicotine specific.
Okay.
Yeah.
All right, my weed smoking.
It's the nicotine that kills your kidney.
What about vaping? I don't vape. I don't know. Is that the same?
Yeah, vaping. Yeah, because it still involves tobacco.
Really?
Yeah. Yep. So even though we think we're not getting the same amount, we're actually in some ways getting more tobacco exposure. So vaping is not the way for many reasons.
Okay. Well, let me ask you this: on this vein of smoking, right? When it comes to smoking marijuana, are there any when it comes to smoking marijuana, is it healthy for you?
That's a big question. So it depends on why you're using it.
Because they say it's from the earth.
It is from the earth. But everything affects the body, right? Even if it's from the earth. It depends on why you're using it. I mean, we have multiple research studies that show that there are medicinal benefits to using it, right? Okay. So, the classic one's glaucoma. It's kind of a joke, but it's for real. Okay. Glaucoma, nausea, and appetite suppression from cancer, chemo, chronic disease issues, anxiety, ADHD. There are a lot of things that we now know that it helps medicinally for. Okay. Recreationally, it's not yet legal everywhere for recreational use, but rarely we see people that deal with bad effects, whether it be long-term, there's also this argument as to, can people become addicted to marijuana? The answer is yes. There are some that have become addicted, or it's become the gateway to using something heavier or more toxic, more dangerous. So you always want to be careful, but there are many medicinal benefits we now know that it helps.
Okay, great. So does it affect your lungs or anything?
Not that I can think of.
Okay.
Definitely not like nicotine.
Okay.
No, there's no lung cancer that's been linked to marijuana.
The doctor cleared y'all.
The truth.
Okay, well that's great. No, it's great. That's a real question.
Yeah.
People out there, that's a real question. I've heard mixed things. All right. So staying in the same vein though, when it comes to your kidneys, right? You said sometimes when it gets to like kidney failure and people need they need dialysis, it's so far gone. What does that look like? So it doesn't have to get that far. What are some of the symptoms of kidney failure?
Yes. So to kind of take a step back, before kidney failure, creatinine is kind of one of the main things in your blood work that we check and should be checking, and that's the way that you can tell that, you know, what your kidney function is looking like well ahead of any problems, right? And that's whether or not you have diabetes and high blood pressure. When you get your electrolytes checked, your metabolic panel, your creatinine is one of those numbers in there. And if you don't see it on there, you need to ask, are we checking up on my kidney function, my creatinine? That, and then your BUN, which stands for blood, urea, nitrogen, and those two things, with those two things, and with other electrolytes on your panel, they can calculate your GFR, or your filtration rate. So those are the big three things that you look for in your blood work. If you're an adult, getting your physical exams every year, get your blood work every year, that's there. But once you start to see your creatinine inching up and your GFR going down, meaning the function of your kidney going down, is when that should set off an alarm. That should be a red flag. And that's when you should start having conversations like, you know, why did my creatinine bump up from 1.2 to 1.4? What happened? Might have been you didn't have enough fluid or enough water. You know, you might have been dehydrated. You went out and had a good time this past weekend. You didn't drink enough water. You had too much alcohol, whatever. That can resolve. That can go back to normal. Or you start a new medication for your blood pressure, or you start a new medication for pain, and it caused a bump in your creatinine, but hopefully you can kind of decrease your use, hydrate, that number will come back to normal. But if you continue to see it going up, that's when you should ask the question, what's happening? What's going on? Like, do we need to be doing further tests? Usually after that, they start talking about, you know, checking your urine for protein, or checking your urine for blood. Those, along with your blood work, can kind of give you a picture as to what the cause is and what you need to do to fix it.
Okay. So let me ask you, what would be, because that's if you get tested, right? What are
the physical stuff?
Yes. What are some physical symptoms that, you know, you might be in the early stages of kidney failure? So
the complicated answer is there may be none. There may be none. Once you get to, unless you've had, unless it's something obvious like a kidney stone or a kidney infection that is gone untreated, that's gonna hurt. You're gonna feel that in your back, in your front. It's gonna be uncomfortable when you pee. But end-stage renal disease from high blood pressure, from taking ibuprofen a lot, from taking whatever.
You can get it from taking ibuprofen?
Absolutely. So there are drugs that are nephrotoxic, you know, toxic to the kidney, like ibuprofen. And we take that stuff over the counter all the time, right? For headaches and menstrual cramps, etc. Almost anything but Tylenol can hurt the kidney. So you have to be careful. Take it as directed. Only take it when you need it, right? So you just have to be careful.
What about aspirin?
Yes.
How much of this do you have to take before it starts to hurt your kidney?
Everybody is different.
Okay.
Everybody's different. But, you know, the gold standard is just to look on the back of the bottle and take it as recommended for your age. Yeah.
What about pain medication? So I know nephrotoxins, I'm not familiar with that term.
It's bad for the kidney.
What is it? Okay. What about like pain medication? Like if a person's on like, I don't know,
like Percocet or something.
Percocet,
so those have more Tylenol in them. So not so much. Now they're opioids. You have to be careful with those for other reasons. But things like almost any of the anti-inflammatories. You know, I don't want to start throwing out brand names here. But anything that you take for the NSAIDs, right? Anything in that ibuprofen family, be careful with.
Wow.
Yeah, you don't want to don't overuse any drug or medication. Only take it if needed.
So let me ask you, if a person, let's say maybe catches something early, right? They have their lab work and they catch it early. Is it possible for early stage kidney failure to be reversed?
That's a hard one. So yes and no. So let's say you've been treating your diabetes well, you've been keeping an eye on things, Your creatinine over time just kind of bumps up a little bit, but it's steady, it's slow. You're keeping an eye on it. There's no protein in your urine, right? All those things are true. Let's say that then you go out and you run a marathon and you are working really hard and your muscles are burning and you're not drinking a lot of water. You can have a bump or a worsening of that creatinine that will then come down. It won't go back all the way to normal, but it'll come back to your baseline, right? If you, for instance, trying to think of another good example.
Well, you said something interesting. You said running a marathon.
Mm-hmm.
Can exercising lead to kidney failure?
Yes, there's a condition called rhabdomyolysis or myolysis that involves your muscles doing like an exorbitant amount of exercise that your body is not used to without hydrating well. It causes muscle breakdown. Those muscle proteins kind of get stuck in the kidney and can cause kidney failure. That thankfully is reversible because then once you feel it, and your muscles hurt and you're lethargic and you can barely move and all that. Or if for your population, the senior population, who falls.
Yes.
So they fall, they're on the floor for a while, injured or have bruised muscles, that then can cause rhabdo. Thankfully, once you get that checked, you'll check your CK level, which is part of the muscle fibers. You'll check your creatinine, get hydrated, take the right types of medicines, and that is reversible. Yeah.
Very good.
Yeah.
Very
Yeah.
good.
Yeah.
Yes. All right. So, all right. You recently shared a transplant survivor story
Mm-hmm.
in an essay. What surprised you most from those conversations, and what do families often misunderstand about donor transplants, living donors transplants, and life after surgery?
Yeah, shout out to my neighbor and friend who helped with that interview. So what I was impressed by, I'll say, is how much she knew ahead of time. So middle-aged Black female, otherwise healthy, doing great in her career, family, no problems. But shortly after pregnancy, I think, is when she started to be aware that her kidney levels were changing. Now, the benefit for her was she had already known her family history. Her mom and like multiple siblings in their family had been diagnosed with PKD, polycystic kidney disease, and had transplants. They actually donated to each other.
Okay, so this ran in her family.
Yes.
Okay,
yes.
The polycystic kidney disease that you talked about earlier ran in her family.
Yes.
Okay.
It's an autosomal dominant disease.
All right.
Mm-hmm.
All right.
So she knew about it. Thankfully, she knew her family history, which is, by the way, big. We all need to be talking to our family members and what did grandma have and what did auntie have and all that.
Does insurance cover this testing?
So the only testing that she did outside of, like I said, the creatinine and all the norm stuff that we would get is, I believe they were doing ultrasounds a little bit earlier for her. There's no screen necessarily, but they were looking at ultrasounds sooner for her. And because she was doing well, they weren't alarmed. But what I was impressed by was that she was very proactive. She said, okay, if my creatinine gets to this level, this is when I'm going to ask for a kidney specialist, right? A nephrologist. And once I'm with my nephrologist, she actually ended up going to a second one because she didn't really like the first one. So she went to the first one. She was like, I don't like you, give me somebody else. Good for her, advocating for herself. Got a second one, was bombed. She was like, yes, you are the one that I trust. And then they were very proactive in when she made the decision to start dialysis. That can often be the decision between how long your kidney's going to last or how early you have to get a transplant, right? So she said, if we need to start dialysis, she started to feel some of the like pain and pressure in her back, and I think she was having some urinary issues. She said, if we're going to start dialysis, let's go ahead and start it early. I don't want to be late to the game. I want to preserve at least some of my kidney function, right, while I wait to potentially need a transplant. So the other thing that I was really impressed by, other than her already knowing her family history and being proactive, was that she said, if I have to have dialysis, I'm going to do it at home. I don't want to go to a dialysis center because that could be really like traumatic for some people. It's, 3 or more times a week, and you got to be there for hours and hours and hours. And it can be really uncomfortable and cold and all that stuff.
People die there.
That's right. So she said, I know I want to do it at home. So she was very proactive in getting that process started too. Once dialysis started, she said, okay, now this is when I'm going to talk to people about being my donor. And her brother ended up being her donor.
Wow.
Yeah. So she was like ahead of the game. She was like, if this happens, I know I'm doing this, and then this, and then this. And it worked out very well for her.
one thing with her, she had the support. You know,
Mhm.
she definitely had the support. So let's talk about that. You know, her brother was her donor.
Mhm.
If you donate a kidney, because we have two,
Mhm.
if you donate one, can you still have a normal life?
Yeah, he's thriving and doing great.
Does it affect your lifespan?
No,
Only have one kidney?
no, you just got to treat that kidney really well. Treat that one you have really well. But no, people live, and that, that's wonderful for now versus maybe what it was right a couple of decades ago. That might not have been the case. They might not have had the right kind of meds and the right kind of things in the surgery planning that we have now. But nowadays, thankfully, people can live wonderful lives with one kidney.
Okay.
Mm-hmm.
I know part of protecting your kidneys is the alcohol.
Mm-hmm.
Is there a safe limit to the amount of drinks you can have and still preserve your kidney?
So I would say not necessarily, when I'm thinking about what the normal or healthy amount of alcohol is, I think it's just for everything, right? So it's the same for protecting your heart, same for protecting your brain. When it comes to beer or wine, in moderation really is key. You don't have to drink alcohol at all. But if you are going to drink alcohol, an average, let me make sure I don't want to misquote, and it's different for men and women because we're usually different heights, different weights. But in general, the average of one per day essentially is okay. If you're doing like one, if you're doing like 2 to 3, you're probably pushing it, and that's servings of, right? So a serving of beer is this, but a serving of liquor is this, right? A serving of wine, even though our wine glass, the glass itself, even though it's this big, that does not mean that's one healthy. That's an American size wine serving. Really, the serving should be here, right? That's one healthy glass of wine. So moderation is key. You don't have to drink alcohol at all, right? But if you are drinking alcohol, my kids are already saying, "I'm not drinking alcohol." I'm like, good for you.
I mean, alcohol consumption has gone down over 40%.
It has.
Yes, it has. So
which is good.
That's really good. So when it comes to alcohol, if you have beer, wine, or just liquor, right? Which one is better for your kidney? If you have to pick.
There's no one that's better for the kidney.
Really?
For your heart, I know everybody's like, "But what about red wine? That's your heart." But there's no good alcohol for your kidney.
Okay. All right.
Sorry.
All right, listen. With that, we're going to conclude our time.
Yes.
Listen, I so appreciate